much for having me today. Thank you for this opportunity to raise awareness about skin cancer, about what we do in medical oncology, about the division of labor between the dermatologist, the surgeon, and the medical oncologist like myself. Um, the title should have been changed to Pearls of Wisdom because I only have 25 minutes to talk about this topic where I need hours and hours to give you all the details. What I'm going to try to share with you today is what red flags you need to be on the lookout and how to approach a new diagnosis of skin cancer. And that's why I added Pearls of Wisdom to the title of this presentation. So, the things that we're going to cover today are the main types of skin cancer. What are the signs? What are the symptoms? How do those lesions look like? What are the risk factors for developing skin cancer? Who makes the diagnosis? What are the treatment options? And where do the specialists come in? So let's start by covering the basics. The way we divide skin cancers is into two large buckets. The melanomas, which are the scary ones that you hear about in the news and the celebrities and people who are sick, and the non melanomas, which are very common, and these are the basal cell cancers and the squamous cell cancers. Let's start by talking about the non melanomas. Basal cell carcinomas are the most common types of cancer in the United States. They're more common than your lung and your pancreas and your colon because the skin is the largest organ of the body. And so it is the organ that is most exposed to outside environmental factors like radiation and UV light and chemicals and so on and so forth. So basal cancer is the most common type of cancer. And I just posted here a picture of how it would look like. It's pearly, waxy in appearance. It's almost like rubbery. It's raised above the skin. It's very friable if you're shaving or you're drying your hair, if it's on the scalp or any sun exposed area, it bleeds easily. It grows slowly, so you might have noticed it somewhere else. Somebody has noticed it a few months ago. It's slow growing. It rarely metastasizes unless somebody has a very weak immune system. The second most common type of skin cancer is your squamous cell cancer. They're cousins of each other. And when we use those words basal and squamous, we are referring to the subtype of cells on the skin. These are natural cells that developed the mutation and they developed into a cancer. The squamous cell cancers, they tend to be more flat. They appear red and inflamed. They are they come from previous uh, thickening or scar tissue on the skin. They are more common in fair-skinned individuals, and these ones tend to have a higher tendency to spread. Again, in general, very rare, but it's a higher tendency to spread than the basal cell cancer. So far, the common themes that you've heard are these are in areas that are exposed to the environment, whether it's UV light, sun exposure. They rarely spread unless somebody has a weak immune system. And the treatment is very easy. This is not a cancer that's hiding inside the body. This is a cancer that you see with the naked eye. This is a cancer that if you go and see a dermatologist, he will look at it, he or she will biopsy it and remove it. Surgery is the treatment, and it's easy because it's superficial. You can see it and take it out. This is the what we just talked about are the less scary types of skin cancer, the ones that grow slowly, They spread slowly, but the ones who have the bad reputation are the less common but more aggressive forms of skin cancer, which is the malignant melanoma. What is the melanoma? Melanoma is a cancer of the moles. So if you have those hyperpigmented brown lesions, those, when they turn into cancer, they become melanoma. But that is not the only way a melanoma can start. That is the misconception that I was hoping to clarify today. Because those moles, these are the cells that give, the pigment to the skin. So the mole is what you see, but you have those cells that produce the pigment all over the body in sun exposed and non sun exposed areas. So you don't need to see a brown spot or a freckle or a mole to say you're going to get melanoma in that area. It can happen on what you perceive as normal skin, but microscopically, you can have a melanoma start in that area even if you don't see the mole. So I wanted to clarify that because I hear patients tell me, Doc, I mean, it's my hand. I look at it every day. I never saw anything. And all of a sudden this popped up. I thought you had to cut a mole for it to become a melanoma. And that's the misconception that I wanted to clarify today. The To go back to the common way melanoma start in the moles, the red flag symptoms that you'll notice that should prompt your attention to do something about it is a change in size, a change in color, ulcerations, and bleeding. So pretty much any change that you see in those areas. Those melanomas, they tend to happen in younger patients who haven't lived long enough to be exposed to the sun like your other squamous and basal cell cancers. They also tend to spread more easily, and that is why they are scary. They are not as common as the cancers that I talked to you about earlier, but they tend to spread more easily. The risk factors are the top two risk factors that I have listed here are common sense. This is what most people pay attention to, which is UV radiation and sunburns. But I also wanted to bring to your attention the less common, less recognized risk factors, which are Parkinson's disease and genetics. We are now learning more and more that melanoma is not only a skin that can skin cancer that can pop up, but it can also be an inherited skin cancer. Genetics play a role, so family history plays a role. If you have a dad, an uncle, a brother, or a sister who already had melanomas and you're fair skinned and you notice a change in a mole or a new skin lesion that appears asymmetric, your risk of having a melanoma is higher than the average population. So we think of genetics when we talk about breast cancer and ovarian cancer. So another thing that I wanted to bring to your attention now is to think about family and genetics when we're talking about melanomas. This is how a melanoma looks like. It tends to be flat. It tends to have irregular borders. It tends to be darker in color, not like the beefy red inflamed spots that I showed you earlier. And when it grows in size is when you need to start worrying. So what do you do when you see a spot like that? How do you address it? The other ones, you feel comfortable, it's been slowly growing. I'll make an appointment with the dermatologist. I'll see them next month and they'll shave it off. But when it comes to the melanoma, you have to be more proactive. You have to seek medical attention sooner than later. And what is the dermatologist? You have to go and see the dermatologist, but what is the dermatologist going to do? If it's just that superficial spot, again, a misconception when people hear melanoma, the first thing they ask about is a PET scan. Doc, I have melanoma. We got to do a PET scan. We got to do a CAT scan, make sure it hasn't spread. When in reality, we don't want to expose the patients unnecessarily to more radiation. So we only use the CT scan and the PET scan for later stages of the melanoma. If it's an early stage, stage one or stage two, it's biopsy, it's removing the cancer. So cancer can be anywhere from stage one to stage four. Stage one is very early stage, and stage four is when the horse is out of the barn and the cancer spreads to other organs. Stage two and three is what is in between. So when it comes to staging melanomas, and this is another pearl of wisdom if you want, for most cancers, most people think size. How big is it? They want to measure it with the tape and see how big it is. Melanoma is the exception to the rule, where the size does not matter, but it's the depth of invasion. That is what helps determine the stage. So it's not how the melanoma is spreading on the skin, but how deep it goes inside the skin. And we can only determine that after we do the biopsy and actually after we remove the whole thing. The biopsy is just to take a small bite of the apple and know what it is. But to really determine the stage, we have to go deep in, do what we call a wide excision. And the dermatologist, not only is he going to go around it, but he's going to go deep in and go down to the bone almost, not always, but remove it. And that is how we know the stage. It's the thickness. Now, if it reaches a certain thickness level, and I'm not going to go into the nitty gritty details of it, that's more of a medical thing that the dermatologist will explain to you in clinic. But if you determine that that melanoma is thick enough, the next thing the surgeon is going to do is to remove a lymph node. So let's talk a little bit about that. The dermatologist did a biopsy. The dermatologist made a diagnosis of melanoma. The next thing they're going to do now is they're going to say, this is a more serious cancer. Go and see the surgeon. And this is what the surgeon is going to do. We all have these lymph nodes or glands behind our ears, neck area, armpit, chest. These are glands that act like filters in our body. When you have a bad cold, the glands in your neck swell up. When you have a spider bite, the glands in your groin swell up. These are filters that the body uses to filter infections. When you have a cancer that's trying to spread, those filters will capture that cancer. And what the surgeon is going to do is they're going to inject the dye in the cancer, try to find the lymph nodes that drain the cancer, and remove those lymph nodes to see if the cancer is trying to spread to the rest of the body or not. So they'll go, this like this picture shows you, they'll inject the dye, they'll find one or two lymph nodes. This is called a sentinel lymph node biopsy. The sentinels are the guards that stand at the gate. So they'll remove one or two. If the cancer is in the lymph node, now we're talking about stage three. And if it's not, we're talking about stage one or two. So to go back to my earlier slide about the workup and when do we do the PET scan and the CAT scan and how do we know if it's a stage one or two or three or four, it starts with the surgery. So the surgery has two roles. The surgery is treatment of the cancer and also staging. So it's not just we're going to do the surgery to take care of the problem. We're going to do the surgery to find out how big the problem is, what stage that cancer is. And so that is the role of the surgeon in the universe of melanomas. And so once they do that, That is when you come and see somebody like me, the medical oncologist. My role as a medical oncologist is to prevent the cancer from coming back. If it's a stage 1 or stage 2, the surgeon has taken care of the problem. If it's a stage 3, this is where my role comes in as a medical oncologist because that is when I need to use modern medicine to reduce the risk of the cancer spreading to other organs in the body. And the modern medicine that we have today for melanoma is called immunotherapy. It's a relatively novel concept in the treatment of cancer, and it's using the power of the immune system to attack any cancer cells left behind. So when the patient comes in the door and tells me, Doc, I had a melanoma and it went to the lymph node, I offer them an infusion or a treatment for a year that boosts the immune system to attack any possible microscopic cancer cells left behind. And that is the concept of what we call adjuvant treatment. The cancer is out, but we're trying to lower the risk of it coming back. Now, if you do your Google search, you'll find out that there are some people who take pills instead of the infusion, but that's only about 15 to 20% of cases where they have a particular abnormal DNA abnormality and they are eligible for taking a pill instead of the infusion. I don't want to talk too much about the pill. I'd rather focus on the infusion because that's what we do most, the immunotherapy. That's the hot concept today in the treatment of a lot of cancers, but especially the melanomas. It's a fairly well tolerated treatment. It's a benign treatment for the most part, except when the immune system goes crazy and it starts attacking the own body cells. Again, I need hours and hours to talk about what immunotherapy is. Today, it's just pearls of wisdom. So, the pearl is that after you take a melanoma out, there is something you can do to lower the chance of it coming back. And that something is not what you see on TV. It's not chemotherapy and throwing up in a bucket and covering yourself with a blanket. It's modern treatment, very well tolerated for the most part, that can lower the risk of the cancer coming back. If the cancer spreads, then we have to use the big guns. We still use immunotherapy, but this is the time where we start combining drugs together. We use what I would like to call heavy artillery. We use the most aggressive treatments we have, and not as one drug, but we combine them together, and so that we can give the immune system a bigger boost to attack the cancer when it spreads. So I hope I was able to clarify some misconceptions today. I hope I was able to make you aware of some of the red flags to look for in skin cancer. And now I'm happy to answer any questions that you have.
Feel free to unmute yourself and you can ask a question or you can type it in the chat box. And while people are thinking of their question or getting ready to type it in, I actually do have a question for you, Doctor. The first question is, what types of things can we do to prevent this from happening from the beginning, outside of, wearing our sunscreen and staying out of the sun? Are there other things that you would recommend that we do, especially in terms of as we get older age?
What you just mentioned, prevention is the best thing to do. Avoid sun exposure at a young age. We're not talking about 20s, we're talking even younger, from childhood, especially if you're fair skinned. So avoid exposure is the number one way to prevent this. Uh, Another thing that you can do is just be aware of the signs. So if it happens, it's caught early on. But there is no proof of any supplement. I mean, there's a lot of talk about that online, blogs and information. Unfortunately, I do not have any training in natural medicine, so I cannot comment on the homeopathic realm of things. But there is no vitamin that you pick up off the shelf and take every day to prevent these from happening. It'll be just environmental risks and reducing exposure to UV light. This is how I look like, but I have to wear a mask.
Well, we
Yes.
have your picture there too. So I know we're all wearing those. It's a good thing. Um, any any other questions? Actually, I do have a question from, excuse me, because I have multiple screens. From Patricia, she is asking, how long does treatment take?
The infusion itself is half an hour to an hour. If that is what we're talking about as far as infusions go, which is what I do, that's it's a matter of half an hour to an hour once every 2 to 3 weeks. The surgeries themselves, they're not, I mean, we use the word surgery, but we're not talking general anesthesia. They call them Mohs surgery, MOHS. Those typically take 30 minutes because, they have to prepare the skin and sterilize it and use their fancy equipment to microscopically take all the edges out, but it's usually short.
Thank you. Um, One of the additional kind of clarification, you mentioned that the early stages of melanoma, you don't recommend the PET scan or the CT scan.
Correct.
Can you just kind of explain why? Because I know me personally, I've had a CT scan, which, you're always afraid of that additional radiation that gets in the body. Is that the primary reason why you don't recommend that in the early stages?
That's correct. It's weighing the benefits and the risks of what we're doing. Every time we offer a patient a procedure, there's always a risk. And to add a little bit more about that, the CT scan, it's not, if it has to be properly done, you have to give a dye, a colorant, inject a dye before they do the CT. It's called contrast. So, one, we're exposing the patient to radiation. Two, we're exposing them to a dye that could damage the kidneys. Three, you run into problems where you start finding these incidental things and it creates a mess. Somebody had a melanoma in the back, but they grew up on a farm. We do a CT scan. We find a spot in the lung. Now what do we do? We're creating more anxiety. Is this cancer? Is this something that they inhaled? Let's do a biopsy. Now we do a biopsy. We get all the complications on the biopsy. It turns out not to be cancer. So there's this, there are consequences to every test that we order. And so we have to be wise when we order those tests and order them in the appropriate setting. So it's all of that and not only the radiation exposure.
Thank you.
Yeah.
I have another question. Um, how Cynthia and Chuck ask, how bad is squamous cell cancer on the ear? They said it's invasive.
The devil is in the details. As bad is a very subjective term. The ear is a sensitive area because it's a thin skin and right below it there's cartilage. So there's not a lot of thickness where the dermatologist or the surgeon can go in and scrape and shave and there's still skin left below. The skin is very thin. I don't know what bad means, but sometimes that cancer, they cannot shave it. There's some cancer cells stuck to the cartilage of the bone of the ear. And so they might have to either cut a piece of the ear out or for cosmetic purposes, if they don't want to do that or cannot do that, then they have to do radiation to that area. The concept is leave no man behind. You don't want to leave any cancer cells behind. So not just the ear, anywhere in the body. If you cannot guarantee that you're going to take everything out and then some more to make sure that you took everything out, then you have to start thinking about other things like radiation, just to get rid of any witnesses left behind, so to speak.
Thank you. Lynn asked, is there a high percentage for her daughter to get melanoma because her dad had it?
Very tricky question. A high percentage, I cannot say that based on the limited history that I have here. Just one parent who had it. So it will take a little bit more of taking family history, an extensive family history, grandparents, uncles, aunts, siblings, the age at which the dad was diagnosed with melanoma. That matters a lot. Was it 35 or 65? So that matters a lot. And I would say higher than the average population is the best statement I can make, but I cannot quantify it without having more extensive history.
She did give an additional note. She says she had abnormalities from one biopsy. Her father passed at 44.
The father who had the melanoma passed at 44.
Yes.
I will commit to the earlier statement, higher than average. My recommendation would be annual skin checkups for the rest of their life, once a year at least. And when we say skin checkups, we're not just saying like with the naked eye looking at the skin, but then they use their special light to make sure they don't miss those small lesions hiding.
Thank you. Do we have any additional questions for Dr. Adimi?
Now I see the chat after I stopped sharing my screen.
Oh,
Okay.
there it is.
Yeah.
And if you're unsure of how to use the chat box, again, you can unmute yourself and ask the doctor your question. I have a question. I know so, as an African American woman and family members, I am very blessed that I don't have any family history of it, but just ethnic people in general and us having darker skin, is there less of a chance to get skin cancer?
Thank you so much for asking that. The answer is absolutely not.
No.
Absolutely not. That's a misconception that people who have darker skin are less prone to have melanomas or cancer. Not true at all. Thank you very much for asking that. Not true at all.
Well, if there's no other questions, I don't want to keep the doctor here any longer. So last chance, last call for questions. This is a great time to get those questions answered from the expert. Okay, well, Dr. Dimi, I don't see any other questions. Thank you so much. This was very, very informative. We really appreciate you taking time out of your day to share with us information about skin cancer. And we definitely, I know I personally learned a lot.
Thank you very much for having me. It's my pleasure.
Thank you. Thank you everyone for joining us, and have a great afternoon.
Bye-bye.